So the VITAL trial was a study involving the combination of vosaroxin with infusional cytarabine for the treatment of acute myeloid leukemia patients. And basically it was a phase 2 study where trying to build upon the earlier data, knowing that vosaroxin in combination with cytarabine had enhanced activity, and also pulling from the VALOR trial, which was a relapse refractory patient population that unfortunately failed to meet its primary endpoint, but did, I would say, demonstrate activity of vosaroxin in the AML patient population. So we decided to utilize a frontline trial design and combine vosaroxin with infusional cytarabine. And with doing so, we first elected to sort of select out higher risk patient population by age, patients who were age 55 and above, as well as those patients who were 18 to 54 who had high risk features. So the patients could receive up to 2 cycles of induction chemotherapy of the vosaroxin. If they required a reinduction, then the dose of vosaroxin was reduced, as was similarly done in the VALOR trial. In regards to the overall outcomes, the median age of our patient population was age 63, so it was an older age population. And about nearly 30% of our patients had P53 abnormalities. Also, it was roughly about 36% of our patients who had poor risk karyotype features. So taking that and moving forward, when we did go through the experience of this combination, it appeared to be reasonably safe and fairly well tolerated. Unfortunately, there were 3 grade 5 events where 2 were related to infection and sepsis, and 1 of those was related to neutropenic colitis. Otherwise, the toxicities that we had seen with this combination seemed to be similar to what we would expect to anthracyclin-based combinations. As far as the response rates that we had seen, the primary endpoint of the study was CR, and we demonstrated a 48% CR rate amongst the patients. The secondary endpoint was the combined CR-CRI rate, and we had 55% of patients achieve that level of response. Again, relative to the older age population, relative to the higher risk features that many of these patients possessed, we feel that this demonstrated very reasonable activity for that population of patients, and 45% of our patients were ultimately able to move on to allogeneic stem cell transplantation. So that remains to be determined. There are active studies which are ongoing with vosaroxin, and to further flush out its role in both the high-risk MDS as well as the AML patient population. What I would like to see done is to see additional studies that are done with this combination in hopes of trying to demonstrate it as maybe being a replacement for anthracyclin-based induction in the frontline setting. The activity that we've seen seemed to be similar to and on par with what we would expect for anthracyclin-based therapy. But the one nuance and appealing aspect of this drug is that vosaroxin isn't an anthracyclin. It's an anti-cancer quinolone derivative, and it does not appear to have cardiotoxicity like the anthracyclins do. So the implications are, again, I think hopefully providing a safer alternative for patients, given that some patients who get anthracyclin based treatment regimens ultimately end up with things like cardiotoxicity or possibly even secondary malignancies. And I think if we can provide the same level of benefit, maybe better level of benefit in regards to clinical activity, but a safer profile and reduce those late-term side effects, it would be a meaningful implication.